coming. This is a bigger turnout than I expected, so this is great. We may run out of food, so I'm sorry about that. Next time we'll plan on ordering some more food. So, but yeah, so we've been talking, if you guys have been paying attention to the Facebook Pain Forum, it's been a topic that we've talked about quite a bit. And what I've done with it in regards to this presentation is, Eric and I went to a 2-day conference back in the fall, and it was about the heroin epidemic that's going on in Indiana. They're considering an epidemic, and also nationally it's considered an epidemic. So I wanted to share that information with you guys. It's really good, and it's kind of know, like, how did we get to this position? We're seeing a lot of admissions now where people have heroin abuse, opiate abuse of all ages and all backgrounds. So I'll go ahead and start. Did I turn it off? Okay. All right, so this is the problem. What's been going on? It's a public health emergency. We've got about 1.9 million Americans that live with opioid misuse or dependence. Over 500,000 Americans live with heroin addiction, and that's continuing to escalate. And then in 2010, they accounted for over 135,000 ED admissions, and with a total cost of over $2.3 million in charges. So it's definitely a big problem. It's become an epidemic, and we're dealing with it on a day-to-day basis. So how does it affect us here at West? Well, we actually ran some numbers for 2015 and 2016 and looked at admission codes in regards to the admissions were heroin-related, opioid-related overdose. So based on those admissions, we saw an increase from 2015 to 2016 of 475% admissions related to this. So it's a hot topic for us. It's nationwide, so it really affects all of us. So it's something that I wanted to share with all of you.
Harish, can I ask?
Yeah.
Did you say from 2015 to 2016 that increase was ED admissions, or?
Yeah.
Okay.
Uh-huh. Those are based on those diagnosis codes for
Okay.
and inpatient. Yeah. So how did we get here? So we're kind of flipped upside down. You know, what we've seen generally is in the past 20 years, there's been like a 600% increase in opioid usage in the general population. The United States uses over 99% of the world's opioids, and we have not seen any reduction in generalized pain in patients. So opioid usage is going up, but pain in general for patients is not going up. So what's going on? What's the problem here? That doesn't add up. If opioids were a successful method for chronic pain, then those numbers should correlate, but looking at epidemiological studies, that's not the case. So the bad, opioids and chronic pain. So what we're seeing a lot is, we're seeing a lot of patients who are on long-term opioids. And I wanted to share with you, so about 3 years ago, I did a pain consult. I was asked to do a pain consult on a lady. She was 36 years old, and she was on chronic opioids since she was 16 years old. And so that's 20 years that she's been on opioids, and it's a combination of all kinds, Norco, OxyContin, Oromorph. And it was a lot of times she was getting it from different physicians at different times. Sometimes she'd be without. But she was here for abdominal pain, you know, so she's doing the whole traditional workup for abdominal pain. They really can't find anything, but I was talking to her, and she, she said that she just continues to get that, and it really bothered me, the fact that she's been getting opiates for 20 years, and it's been successful for her. And her problems and conditions are just getting worse and worse. And she's 36 years old, and she had a 6-year-old that she really couldn't take care of. So what's going on with that, and why is that continuing to happen? So pain, basically, just definition, it's a perception which begins with a stimulus and is subject to physical and psychological influence. In some cases, it may be inhibited if there's fear, and then you may not experience that pain as much. And in other cases, it may be magnified if somebody is almost having a need for pain. So in 1957, they tried to quantify pain a little bit. Dr. Beecher attempted to quantify pain by doing an exhaustive review He had over 850 references, and basically the conclusion was, because pain is subjective, it cannot be described so that it's meaningful to another person. So we all know that. It's the way some person describes it as being in a pain as of a 10 out of 10. You know, the way they'd experience it is hard to understand what they're exactly going through. So now looking at pain, you've got acute pain, which is, we all know, that's somebody, you know, breaks an arm, a leg, and they're in that acute pain. Chronic pain, there's two different kinds I'm going to break it into. One is pain of malignant origin, which would be cancer pain. And the other one would be pain of benign or non-malignant origin. So looking at pain, it's not just you break your arm or something like that. There's so many other things that are involved. There's a psychiatric component. There's the neurophysiological component of actually experiencing that pain when you get a cut or a wound. Here's some chairs back there. Emily, sorry. Yeah. So acute pain is basically a response to tissue damage. It's an important biologic function. It's a survival mechanism for us. And for acute pain, analgesics are effective for 1 to 3 weeks. And opioids are appropriate. So somebody comes into the ER after an accident or some injury, it's totally appropriate. They need to be on it. They need to have their pain managed. So by the way opioids were studied, they were only indicated for acute pain only. They weren't really studied for when they first came on the market. Every pharmacokinetic study is based on an acute pain model and some kind of noxious stimuli and seeing the response based off of that. So let's talk about chronic pain of benign origin. That's something like, you know, chronic back pain. That's something that's non-cancer. So you have tissue damage at the onset. It becomes chronic when it lasts for greater than 6 months, and this persists due to that tissue not returning to normal function, and it can also be worsened by psychological or pharmacological factors. The treatment for chronic pain is rehab. As with any other disability. It can be short-term opioids, but then it goes into non-opioids and rehab. You have to strengthen those muscles. You talk to all your PTOT friends back there, they'll tell you that you got to strengthen those muscles and move and get the blood flow going again. And that's the way it's recommended. For chronic pain of malignant origin or cancer pain, so in this scenario, by all means, opioids is appropriate for. This is, you know, tissue damage is there due to some malignancy and it's not getting better. Sometimes the chemo, the treatment is causing that problem also. It's causing pain. So in these situations, the treatment is pharmacologic. You have to escalate opioids depending on tolerance, and then parenteral and intrathecal administration is appropriate. And then once again, physical and psychological rehab is only going to help too in these individuals. So chronic pain syndrome. So this is the basic definition and what makes it worse. So this is greater than pain that lasts for greater than 6 months. Factors that worsen pain for chronic pain is one is the top of the list is opioids and other narcotics. This is for non-malignant pains, for benign non-cancer pain. And what they found is, you know, also what worsens it is depression, physical regression, psychological regression, and intolerance. And this is, you see this a lot. You know, people who have chronic pain they feel very defeated, and then they kind of get into this cycle of not motivated, and they are less active, that they're less socially engaged, and then of course because of all that, they may not be able to work and so forth. So there's financial stresses and so forth. So that happens. Opioids, negative effects with chronic use. Well, one, tolerance eliminates analgesia. Second, withdrawal increases pain. So if they can't get their pain, they go into withdrawal, and then they're more sensitive. So it suppresses endorphins, which is our body's natural painkiller. Suppresses testosterone and estradiol, which can affect their mood and well-being, which then worsens depression. If you're on chronic opioids, there's a good chance you will have a lifetime prevalence of addiction. And then secondly, or lastly, pain improves with detoxification. So that's the hard part, though. You have getting to that point, and then working through it. There's a whole group downtown at Methodist that has for chronic pain and addiction patients. And these patients are addicted patients who have chronic pain issues that don't take opioids. And that's, I know Jim Reiser leads that group, and you find they're successful and they do well and they're functioning well in life, and they're from all walks of life. So it's definitely doable, and people are doing it. So this is the cycle. You know, you have pain, you go to some narcotics, people have withdrawal, they have more pain, more narcotics, and we're seeing this over and over again. This goes on for that individual for years and years. Like in that one patient I talked about who started opioids when she was 16 and now she was 36 and still on it. And she had a lot of shame and guilt. It was very obvious. She was not happy about her situation. She did not want to use constantly. You know, she felt judged by nursing staff and medical staff. But at the same time, she didn't know what to do. And at one point, she was willing to go to the treatment center downtown at Methodist and try to get help there. But I'm not exactly sure what her outcome was. But this was her scenario that was going on for the past 20 years. So when you have chronic pain and you have depression, it heightens your pain perception. The consequences of disability, you know, it's intensified by, this is all the stuff that happens: family disruption, financial loss, legal problems. You know, so if you have chronic pain, a lot of times and have depression, they recommend starting an antidepressant too to help alleviate some of that. Then there's physical regression. This is basically decreased activity. What we want them to do is moving and participating in like physical therapy and so forth, and strengthening and activity. But oftentimes, because they're in pain, they're not moving around, and then they end up developing muscle weakness, and then their pain increases as soon as they start trying to move again. So they get into the self-defeating cycle and physically regress. Then there's psychological regression. They don't feel social enough. They're not, you know, talking to friends or doing stuff, and so they feel isolated. And then what happens is their life is centered on pain. Everything they wake up in the morning, that's the first thing they think about. So that consumes them. And then, for these individuals, it's really important to feel like they belong and have recreational therapy and physical therapy and kind of be a part of that community again. And actually, a little side note, in Portugal, they don't criminalize a lot of their addicts. What they'll do is they support them to get back into society and give them jobs and so forth. And you have a really high success rate there. At some point, I'd like to look up those numbers, but those addicts in that country are actually socializing better and having better outcomes because of that, because they're not so isolated, because they're not shamed and put into a corner or in jail. So it's a really impressive model that they're following. And there's stress. As I mentioned before, you know, anytime you can't work, you can't do stuff, you can't be around friends, or you have disruption in your family, there's maybe relationship problems, it's going to cause stress, and this is a definite outcome for somebody with chronic pain who is not getting that help that they need. An option for them is biofeedback, relaxation techniques, meditation. It's hard to tell somebody to just go and meditate when they're in chronic pain, but you know, it's something to think about when it's not a quick fix. Chronic pain, the easy answer is, is to take that pill, and what it does is, with opioids, it's beyond just like a mu receptor agonist. It's beyond just blocking those pain. It has a psychological effect. Opioids do decrease anxiety. It does elevate your mood in short term. Chronic use, it doesn't. But so all those things is the quick fix. The hard job with someone with chronic pain is getting up and moving and being active and talking to people and getting the support you need and doing the physical work that will allow those muscles and those tissues and everything to heal itself. But unfortunately, what's happening a lot is the exact opposite. They're just taking the medication and being less and less active. So chronic pain management, Once again, this is non-cancer pain. The problem we're seeing is narcotics, then we're also in depression, physical, psychological regression, stress. The solution is to discontinue and treat addiction. Antidepressants and counseling, increase activity, physical therapy, exercise, massage, yoga, all the stuff that that can help move you. Biofeedback, relaxation, and then guided imagery. So then comes the question, if they are such a poor choice for chronic benign pain, then why are they so popular and why are people using them so much? If you go to any pharmacy, it's probably one of the fastest moving things on the shelf are their opiates. So these are the factors. So I broke it down to three. There's the pain experts, and mad science, and there's pharma companies' influence. So first of all, I'm going to talk about this guy, Dr. Russell Portnoy. I don't know if any of you guys have heard of him, but he is a leading pain expert. And he's an internist from New York City. In the 80s, his mom was actually, it's very unfortunate, his mom had cancer, suffered, was undertreated for his pain, or his mom was undertreated for pain. So he developed a passion for treating cancer pain, which I fully agree with. Give liberally, make them comfortable, treat them. So he promoted that. But at some point, he added non-cancer patients to that list. He started saying, hey, you know what? You need to also use opioids for non-cancer patients. It's beneficial for them. It'll improve their outcomes. There is no ceiling. There's no dose ceiling. Started hearing the whole pain is the fifth vital sign. It became a much more popular thing. He promoted it heavily throughout the 80s and 90s and went around talking and lectured and went to several conferences. Well, in 2012, he became under scrutiny by, he was under investigated by Congress for money and that he was receiving and the influence on nonprofit organizations. But in 2012, he admitted that research had not been backed up the effectiveness of opioids with chronic pain of all kinds, and that the risk of addiction and other adverse effects were greater than he previously indicated. And he's saying that very lightly. I mean, basically he was saying he didn't know, he just kind of made it up based on his feelings. He's on the payroll for Purdue Pharmaceuticals. Do you guys know who makes what Purdue Pharmaceutical makes? That's one of the most popular drugs. They make OxyContin. He's also on the payroll for several other pharma companies too, and there's other pharmacy or pain experts that are funded through several pharma companies also. So I'm going to go back to that a little bit more, but then I'm going to talk about the mad science. So this is a quote by Mark Twain. Get your facts first, and then you can sort them as much as you please. So I wanted to talk about substance use disorder and chronic pain. So now we're starting to see, back in 1980, Porter and Jick published an article in the New England Journal of Medicine, and they did an extensive review of hospital records. They did close to 40,000 hospital records. 11,000 plus received narcotics, but there are only 4 documented cases of addiction of that many. So there are 3 kinds of lies. There's damn lies, and there's statistics. Okay, so Portnoy, Russell Portnoy, who I talked about earlier, the physician, in 1986 in the Journal of Pain, he said, and this is what I was learning about pain and so forth, this is the quote percentage I always said, oh, it's only 5 to 6%. That's what he always said, 5% addiction rate with chronic opioid treatment. That's what I was taught, that's what I learned when I read everything. So that's what I was telling people. I have lectures, and I had talks I've done before where I put that in my slides, and I've got to take them all out now. So now in the Clinical Journal of Pain in 1992, they're saying that addiction rates are up to 19% in this review article. by 2010, at the Cleveland Clinic, greater than 30% of patients in the chronic pain rehab program have an active substance use disorder. So it's steadily going up. Now, in 2007, in this opioid treatment for chronic back pain, so they were looking at the prevalence of addiction in these patients, and then they did a meta-analysis of 38 studies. So they took several studies and they shared all that data. And what they did was they found a lifetime prevalence of people who have chronic back pain. So 54% of them will at some point in their life have some type of opioid addiction. And this was that case with that one patient I talked about earlier, because I think when she had an accident, she had chronic back pain, and that's why she was taking opioids. And now she was having issues with abdominal pain and other stuff. So it's that 5% is definitely not holding up right now. So this is the bottom line. So opioids for chronic pain, there are no studies demonstrating long-term functional improvement at all, but it's used all the time. And there's no studies demonstrating long-term analgesia for chronic pain. So what we're seeing a lot more of these days is something called opioid-induced hyperalgesia. So this is a situation where somebody's been on opioids for so long that they actually become more sensitive to pain. In this study in 1994, they looked at methadone maintenance patients, and they found that they have lower pain thresholds than controls, and they were compared to cocaine addicts and former heroin users not on methadone. So when you have those receptors constantly being bombarded, it starts to become like almost like a rewiring effect. They look at active disease appears to augment the experience of pain. This is the interface between addiction and pain. And there's evidence that suggests that people with addictions have decreased pain tolerance because they're just on it for so long, you know. And then what they're finding is there's a reorganization of baseline perceptual pathways in the brain that results in increased pain perception. So in 1994, Dr. Caleb Alexander, he's a professor at Johns Hopkins for epidemiology and medicine. He basically said, I think we overestimated the benefits of prescription opioids and underestimated their risks. Although opioids have many risks, their addictive potential is of especially great concern. And to tell you the truth, we really don't know like the effect we know the bad effects of long-term chronic opioids. We don't know, there probably are some specific cases where it may be appropriate for some patients to have long-term opioids, but it's probably far and few. And being the fact that we've seen a 600% rise in the past 20 years, but no decrease in pain in the generalized population with some of these conditions, you know, it's hard for me to say that, hey, yeah, chronic pain is good for the non-cancer patient. So, and then this is in 2014, the American Academy of Neurology made a position paper and basically said, whereas there is evidence for significant short-term pain relief, there is no substantial evidence for maintenance of pain relief or improved function over long periods of time without incurring serious risk of overdose dependence or addiction. And you know, we were talking about Russell Portnoy earlier. So what he was doing was he was going around he was taking these guidelines that were produced by some of these nonprofit organizations, and he was going to conferences and telling people, hey, this is how you prescribe opioids. And a lot of those were treating children and non-cancer patients. But studies have shown that there's no evidence of benefit for opioids used greater than 4 months. There's no evidence of decreased suffering, no overall improvement in back and neck pain and disability. And they did a study in Denmark, and the COT means chronic opioid therapy users had higher pain and lower quality of life, and they were less functional.
Harish, I'm curious, though, in the beginning when we started looking at studies where they said there were lower numbers addicted, and then subsequent studies up to 50%. Was that because they were measuring addiction wrong, or because prescribers were changing their practice?
I think,
What caused the change in such a hike in numbers?
well, I think a lot of it was, to be honest, I think a lot of it was a lot of these patients were starting to, or a lot of these physicians were being sponsored by pharma companies that were publishing guidelines. So,
Prescribing.
yeah, they were prescribing, and if you're selling a product, you know, and you want it to sell, but there's a really bad outcome, unfortunately, there's been investigations for some of these companies that have been sued because of that, and because they're basically lying. They're not telling you the truth about the bad outcome. So I think that number of 5% was probably, I don't know the answer of where it came from, but I don't think it was, I think it was a manipulated number through statistics. So then you got pharma companies. So there's evidence of several pharma companies that manufacture narcotics linked to nonprofit organizations. These nonprofit organizations are like American Pain, the big ones, American Pain Society, and so forth. And I have some of these guidelines too. These nonprofits publish prescribing guidelines, position statements, books, and physician education courses. So these are several of the nonprofits, and these are the drug companies that fund them. And for some of these, like for Purdue Pharmaceuticals, that was, or they funded 90% of American Pain Foundation's education sort of stuff. And they have actually been shut down since then, in 2012. They couldn't afford to run anymore because they were sued. And then all of these have been gone under Congress and a congressional investigation. So now what do we do? So the point of me telling you all this is not to just kind of say, hey, these are the bad people, you know, bad pharma, all that stuff that's out there, but what do we do as caregivers is the point. So dosing the addict, you know, how do we deal with this? Because we're going to see these patients more and more in the next 20, 30 years, unless there's like policy and big changes in our country. But as for our sake, for us as caregivers, what we can do is at least know how to treat these people appropriately and have knowledge about it. So addicts, especially opioid addicts, are often require larger opioid doses and more frequent dosing intervals than non-addicted patients to adequately control their pain. So there's 7 principles that I learned about that are to be followed. So principle number 1, acute pain is a medical emergency and should be treated as such. So if somebody has acute pain, regardless if they're an addict or not, they need to be treated for their pain. And you can give them what they need for that acute, reason. Opioid withdrawal symptoms can interfere with attempts to control pain, and the time to detoxify is not when pain management is needed. So when they're coming into the hospital, we don't need to worry about trying to cure their addiction, because we can't at this point. Right now, we just need to make sure they're adequately managed. Principle 2, choose the medication needed for pain relief according to the World Health Guidelines. If you guys Google World Health Guidelines pain management, there's a whole booklet that comes up, and it just basically talks about how to select certain medications, and that's what they're talking about. Reassure the patient that the staff is committed to providing aggressive and effective pain relief. At this point, they're coming in, they need help, they need pain management, and we need to support that. And provide around-the-clock treatment, titrate to a level that provides adequate pain control. So 3 and 4, avoid mixed opioid agonists, antagonists. Those are like nalbuphine, pendesine. Those are like mixed agonists, antagonists. These will, because that antagonist effect, it could precipitate withdrawal. So you want to avoid those medications. Just if you could give anything, just straight mu agonists like opioids, such as Norco, long-acting meds such as OxyContin and things like that may be appropriate for short term. So what the addict is looking for is the high, and the way they get it is short bursts, quick doses, frequent doses. So that's what we don't. We want to really give them scheduled dosing. We want to take control away from them completely, and we want to make sure we're controlling that. So here it says, the high that addicts achieve from opioids is directly proportional to the rate at which the concentration of the drug rises in the blood. Intermittent IV bolus doses enhance the rewarding effects of the drug. So, we see it. People come in, they want the IV Dilaudid. That's what they want. And that's kind of natural. That's what their body's telling them. So IV administration of opiates is less rewarding when administered as a continuous infusion. Now, the only thing is, I don't think, at least at this point, if somebody can't take PO at all, or a patch and they need something, this may be a good option. I know this would be probably, I have to do a lot of talking to some of the physicians in regards to convincing this, but it's better than doing IV Dilaudid, PRN, or scheduled. If you can at least do a PRN, a continuous low dose, and not give them any PCA access, there's no intermittent dose, but just a continuous low dose, that will help better manage their pain and also help decrease some of the withdrawal. Then you want to do long-acting oral opioids, and then fentanyl patch is a good option. Fentanyl patch is a good option. The only problem is there's that delayed effect, so you may have to do something in the meantime until that fully kicks in. So main thing though is structured control, and as many orals as they can for that period of time is the way to treat them. Opiate withdrawal can also be avoided by administering a baseline dose of opiate that corresponds to the patient's usual dose. So whatever, that's why it's important for us to, if they're on some chronic doses, and continue those while they're here, and then come up with a plan with them while they're in-house to continue to treat them. So the bottom line is, the addicted patient is very complex. This is why I'm really glad that we've got a good mix of backgrounds in here as far as nurses, pharmacists, PT, and social work and everything. Because it really takes a team of people to handle these patients. It's way too much for one nurse to go and handle that. It's overwhelming. And if you have a patient like that, please, do a pharmacy pain consult, talk to your hospitalist, talk to us, talk to social work and everything to get involved in this individual, because unless we make some of these little changes now, these patients are going to keep coming in over and over and again. And if they still have that continuous access to all these opioids, and we're giving them misinformation through bad medicine in the early 90s and early 2000s, then I think it's our job right now to kind of help work on changing that culture. So in 2016, this CDC issued new guidelines. Opioids are not first-line routine therapy for chronic pain anymore. They want us to establish and measure goals for pain and function, check their prescription drug monitoring program, we call it INSPECT here in Indiana, use urine drug screens, avoid concurrent benzos and opioid prescribing. We say that all the time. People on benzos and opiates at the same time, and that's a really, really lethal combination, especially if you throw in alcohol in the mix. It's a quick way for somebody to overdose. And then arrange treatment for opioid use and disorder if needed. So if somebody does want help, there is actually a program at Methodist for an outpatient treatment program that actually Jim Reiser recently told us that if you guys have come across a patient like that, you can talk to the hospitals and say they always have open seats there. It's an outpatient program, it's not inpatient, so there is definitely that available for those individuals. Okay, and then to reduce overdose deaths, they want us to limit initiation to opioid misuse and addiction through education of our healthcare providers, expand access to evidence-based treatment of substance use disorder, including medication-assisted treatment for people with opioid use disorder. And also expanding the use of naloxone. That's, I know that's kind of controversial as far as somehow people feel on it, so I'm not sure exactly how I feel, but it's definitely something that needs to be looked at. And then getting state and local public health agencies and medical examiners and coroners and law enforcement to work together to improve on the overall opioid outbreak. And that's it. That's what I had for you guys. Hope you guys had enough to eat, or there was enough pizza back there.